very, very important topic tonight. And I'm so glad Michelle is also joining us, because I think to hear from a patient's perspective, Lou has made all of these webinars available on the website. So, not personal comments or, whatever, just the bulk of the content is available. So if you have friends that you feel would benefit from it, please, they can go and have a look afterwards, and please share future webinar links with them. But welcome and thank you for joining. I'm going to start my screen. So our topic today is, talking to the cancer patient. But now I must first figure out my screen, which is always interesting. Sorry. Share screen. Share, and we can do screen. And I'm sorry for that mess, but let's okay. Lou, how's that looking? Can you guys see okay?
Yeah, that's perfect.
Okay, great. So I'm just going to minimize that. All right. So talking to the cancer patient. And I think this is something that I would be very surprised if you were actually formally taught it in your curriculum. As far as I know, it's not, it receives very, very little attention. There's always the Breaking Bad News lecture tossed in somewhere randomly. But it's an incredibly difficult thing to teach. And I think it's also difficult to teach because so many people are inherently extremely uncomfortable having difficult conversations with people. So I hope that you find this helpful. Just when I thought about it, I was like, okay, maybe these guys actually want something a little bit more academic from me. So let me actually go and see what is in the literature, what is in the textbooks, what are we supposed to teach students when we talk about having difficult conversations. And having conversations with a cancer patient definitely falls within that. So what was very interesting for me was these how the pendulum has swung from historically these quotes. I mean, I just loved it. So the American Medical Association First Code of Medical Ethics stated that the life of a sick person can be shortened not only by the acts, but also by the words or the manner of a physician. I don't disagree with that. It is therefore a sacred duty to guard himself carefully in this respect and to avoid all things which have a tendency to discourage the patient and to depress his spirits. So now the second part of it, there's nuance there. We'll unpack it, but a very interesting quote to remember. And then Hippocrates also, I mean, do with this what you may, advised concealing most things from the patient while you are attending to him. Give necessary orders with cheerfulness and serenity, revealing nothing of the patient's future or present condition. For many patients have taken a turn for the worse by the forecast of what is to come. So that's very, very interesting. And for me, this summarizes so much of what the internal dialogue is for clinicians, for physicians, when we are having difficult conversations. It's that insane balancing act of the obligation to be honest, to the courage to be honest, to share as much information as you can, and at the same time to hold hope alive, to hold a space of empathy, to treat this interaction as really sacred with the patient, which is it's incredibly, incredibly hard. So I hope that with this conversation, we can unpack it a little bit and hopefully can impart a little bit of wisdom to you. But I think the most important thing before we even start this conversation is, I think, two things. One is this is not something that you can learn in a textbook. Unfortunately, it is not something that I can even teach you. I can give you guidelines, I can share my experience with you, but this is something that comes with lived experience. So the more you do it, the not the easier it gets, but the 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 better you get at navigating it. It never gets easy, but you learn how to navigate it. And that comes with doing it again and again and again. Doesn't matter how hard it is, doesn't matter how terrible some conversations go, but it's like a muscle that you can train. And then the second thing is to remember that and be kind to yourself, because not all of us are natural communicators. For some, communication, talking to people, interacting with people, reading other people's emotions come a lot more naturally, or it feels much more intuitive, where for some of us it doesn't. And be kind to yourself. And I think one of the most important things to do is to acknowledge if you are one of those people that struggle with these kind of interactions, to say to senior colleagues when you are still a junior, I would like to participate in this conversation, but I find it really hard. Or to actually, even better, acknowledge it to the patient to say, we need to have this conversation. It is really hard for me. This is not something that comes naturally for me, but I want to be present for you. Just that reassurance that I want to be here. And no matter how good or how bad I am at this, I am willing to be present for you. So back to the academics. I mean, the stuff that I found in the textbooks, and, actually, I can just sigh. So, we can read it. In the past few decades, traditional paternalistic models of patient care has given way to the emphasis on patient autonomy and empowerment. Great statement. We all know it's not always true in practice. And then there's many studies that's actually been done regarding patient preferences and how they would like bad news to be disclosed, especially in terms of terminal diagnosis. What is very interesting is, and this stands directly in opposition to what our friend Hippocrates has said, is that up to 90% of patients actually want full disclosure. They really, really want honesty, as hard as it is. Okay. But then here's the caveat, and this is what makes it so difficult, is a sizable minority of patients. So let's say 50%, so in some studies up to 50% of patients still does not want full disclosure. And all that the textbooks say is the physician needs to ascertain how the patient would like to have bad news addressed. Now, that is it is, what do you do with a sentence like that? So information needs of cancer patients, there are definitely consistent themes. But which theme is most important to any given patient? Again, highly variable. And there's few patient characteristics that accurately can predict what would be most important for which patient. So extremely helpful, right? Extremely helpful what's in the textbooks. Therefore, the physician faces the challenge of individualizing the manner of breaking bad news and the content delivered according to the patient's desires or needs. So full marks if you wrote all of that down in an exam paper. In real life, good luck navigating that. Okay, so I read it and I was just like, it didn't help me one iota. And I think for all of you being present on this webinar, I think you're curious about being better doctors, and I think you would also find that not helpful at all. So let's try and find some things that are helpful. And I've looked at, there are actually quite a few models that's been developed by palliative care physicians, by not really oncologists, also psychologists, to try and assist the physician in navigating these difficult conversations. And I went through quite a few of them to try and find one that I think would be most useful for you now at this stage of your career. But in all honesty, what I've realized going through all of that again is that there are a few things, this is more than 5, I think it's 6 things, that no one can actually teach you. And it is something that is entirely up to you. And unfortunately, or fortunately, we're coming back to something that's a common thread through all these webinars, and that is, my darling children, you need to know yourself, your interior space, and how much space you spend on actually getting to know yourself will serve you for the rest of your life. So spend time reflecting on your own mortality. It's a hard thing to do. And I think actually in medicine, we're quite privileged. It can be very traumatizing, especially if we don't have support, but we're quite privileged to be faced with mortality very early on in life. And if we can deal with that mindfully and reflectively, it can be incredibly enriching. And you can know things that people your own age will not know and cannot understand. But I think making time to actually reflect on that will serve you greatly. Nobody can teach you calmness in the face of distress and trauma. It is something that comes with repeat exposure, unfortunately. I think for some people it's an innate quality and they're very, very privileged to have that. But calmness can also be cultivated. It can be cultivated by exercises that you can do, and it goes back to self-care. It goes back to working on your interior space. So it's breathing, it's learning simple breathing techniques, it's actually certain calming. So I find it incredibly calming to tap or press on my breastbone or even on my forehead, or things that you can do, habits that you can develop that can immediately center you, that can calm you down in a stressful and traumatic situation or environment. It is very hard to teach someone how to support someone in their most vulnerable moment. It is, again, something that comes with exposure. The more you do it, not the easier it gets, but the better you get at navigating it. And it is almost impossible to teach and to know. And I am still learning how to feel empathy, how to really be able to put yourself in somebody else's shoes and not be destroyed by it. Because that is ultimately where we sometimes, you tether on that, on the edge of burnout, is when you feel the empathy, you feel the responsibility, and you're not able to protect yourself. So how we do that, it's not an easy answer. It's not something that a textbook can ever teach you. It's hardly something that I can teach you, but it is something that I think you, whenever is possible for you in your career, to get a support team around you, to get a therapist, get a coach, get a support group, even if it's a group of friends that debrief once a month or whatever. But that makes a huge difference in being able to find that balance. And it's never perfect. It's always a little bit to the one side, a little bit to the other side. The one thing that maybe I'd said nobody can teach us, but maybe this is teachable. But again, it's something, it's so up to you. It's so up to you. It's not part of the curriculum. There is a little bit of intuition that's involved in it, but is to actually read and communicate with someone in language and metaphors that they can hear, that they can really hear and understand. because it's very easy, especially in difficult conversations, for us as doctors to hide behind big terms and complicated terminology and all of it. It can become a really easy scapegoat. No, but I told the patient everything. But meanwhile, the patient did not understand a third of what you were saying. And it's actually to look at material. Look at when you are learning something, when you are studying something. How would I explain this to a child? And coming up with useful metaphors. Not only will it make your own studying more fun, but it really enables you to speak to people in a way that they can hear you. And then something definitely that nobody can teach you is to sit and to be present with pain without fixing it. Because as medics, and I think that's why many of us are in this profession, is because we feel called to heal and to fix and to make better. And there are just some things in life that we can't effing fix. Sorry for my French. And that is a hard thing to learn to sit with, to be present with, to not let it destroy you, to not let it harden you. And again, that all comes back to the interior work that we can do, the self-reflecting that we can do, and building something around us whenever and if possible in terms of growing our own spirituality, our own psychology, etc. Okay, so it's a lot of, yeah. The academics, back to models that actually are available. The one that I think at this stage probably is the most practical for you. It's the one by Roodt and McPhee. So it is actually quite practical and very comprehensive. And they've done literature reviews, they've done qualitative and quantitative interviews with patients, and they came up with this ABCDE sort of model for how to break bad news, how to have a difficult conversation with a patient. And in essence, A, advanced preparation, B, building a therapeutic environment or relationship, communicating well, dealing with the patient and the family reactions, and then encouraging and validating emotions. So we're going to go through this, and I'm going to give you my little inputs with underneath all of that. But on top of that, I've just added one or two extra layers that we call the flaminglets sort of ABCDE, that I hope will add an extra layer to this model for you and make it a little bit easier, a little bit more applicable. So, right. So, advanced prep. Okay. So, and this, I still do it, and I really think it is important, especially the younger you are, the more important it is. Don't let any senior person rush you into having a difficult conversation with somebody. If you know, or if you designated to go and speak to the patient, take the time you need, whether it's 5 minutes, whether it's 5 days. I mean, we don't have 5 days, but I mean, take a little bit of time to actually prepare yourself. So, because there is something that really empowers you. Start with the easy stuff. So start with the clinical stuff, because you'd be surprised how many people would actually enter a very difficult conversation with the patient without having all the clinical and medical facts at hand. So really go and familiarize yourself with the relevant clinical information. Make sure you know exactly what the patient's history is, what the patient's diagnosis is, and be prepared to at least provide very basic information about prognosis and treatment options. So you don't have to go and study all the latest and greatest, American Society of Oncology's guidelines and treatment options. It's not relevant, and especially while you are a junior doctor and while you're working in the public sector. In fact, many of those things aren't available for patients, but at least have the basics handy, because it will give you confidence, it will help center you, and it will help you into this conversation. Again, this is so difficult in our environments, and I find it so sad and it really breaks my heart how difficult it is to actually get it right, but to arrange an adequate time in a private and a comfortable location to have a conversation with the patient. So in our clinics, often it's in a hospital bed where there's no curtains. And I know I say this fully realizing how incredibly hard this is to get right sometimes. But if you can, even if you take a corner in the ward, or if you at least close the door. I mean, it's something that people actually forget, is to, in whatever simple way you can, fully cognizant of how difficult it is in our public hospitals, but to try and create some privacy and some comfort for the conversation. Mentally, you can try and rehearse how you will deliver the news, although I find this not helpful at all because it never goes as I supposedly think it would, or practice or whatever. So this is great on paper, but in real life, it doesn't always. It certainly has not helped me much. But you know, if you have a really good friend that is interested, like I assume all of you are, to actually become better doctors, be caring doctors, you can practice with each other and just say, does it sound, or how does it feel to you if I say something to you in this way? Or put each other on the spot. Great, you need to tell me now. I need to get chemotherapy. And then just see where you naturally go. And then obviously prepare yourself emotionally. So try and do your breathing exercises. Try and center yourself. For our Flamingo ABC, I think in terms of advanced prep, I would like to add to it and accept the task. Okay, it's something that there's a natural sort of reluctance. There's a hinging away from it. There's a, oh, I don't want to do it. I don't want to do it. But a leaning in to saying that this, it doesn't feel like it, but it is actually a privilege, and it is such a sacred human interaction that you are invited into. So accept the task and accept that actually preparation is not just for the individual patient, but in our jobs, the older I get, the more I do this job, I realize that my own preparation is a daily pursuit. Tending to my own emotional health and my psychological development is ultimately a daily pursuit. And it's the only thing that really equips me to have difficult conversations and to have it on an ongoing basis. And we can also do this by proactively seeking out people's lived experiences. Talk to patients, ask them how it was to have a difficult conversation. How did it go? How did you experience that? Read books. They are beautiful books. I'm just the one that's just coming up now is actually a physician that passed away of cancer. When breath becomes air. Read books. It's hard. It's hard material. It's material that we all tend to avoid. We want to avoid it because it's hard. So we don't want to watch the sad movie. We don't want to read the books that feels too close. But it's only by familiarizing ourselves with the real life lived experience of people that we can train this muscle to make it a little bit easier. Okay, so building the therapeutic environment, and this goes beyond the actual physical environment, right? So this is how you interact with the patient. And again, for me, I say all of this, and I know it looks beautiful on paper, but it is so hard when in our public system where there is virtually no continuity of care. You will see the patient once, someone else will see the patient, someone else will see the patient. So it becomes really, really hard to build this. But I want you to remember this, because what I find interesting is that the lack of continuity of care in the public system becomes a very convenient hiding place for doctors to avoid learning to have proper hard conversations, because they know I can chicken out at the end of this conversation because it will be someone else's problem at the next appointment. And people take that with them into private. They take that with them as they become more senior, and they never learn to actually have a proper hard conversation with somebody. So remember this. And I know it's written for ideal circumstances, but I really think that this is something that we could strive for and that we can try and build going forward. So to learn, try and learn, try and figure out what the patient's preferences would be. So that's so hard. I mean, you can ask them straight up, tell them, listen, we need to discuss. We often actually having a hard conversation becomes really, or you can ask, when they did your biopsy, did anybody explain to you why you had your biopsy or what we were concerned about with the biopsy? So sort of preempting it and sort of starting the difficult conversation a little bit earlier, and then saying, so we need to chat about the results. Do you want to bring someone else? What language would you prefer us to have this conversation in? Is very subtle things that you can really use to actually make it a better experience for people. And really, whenever possible, and again, in our state sector, it's so difficult. Patients rarely come with family members. But if you ever have the opportunity to give someone an appointment for results, ask them. Doesn't matter whether it's good or bad, the result. Ask them, with your next appointment, bring somebody with you. Bring a family member or a friend with you. Because having that sense of comfort and security around them, and also having a set of extra ears, because they cannot actually process what's happening. They can't hear you. So having that second presence is so important. So when you do a biopsy or you book somebody for a difficult examination, and you may not be the doctor that's actually going to give that result, tell the patient, we're doing this test now. When you come in for your results, bring someone with you. Okay. Very simple. Introduce yourself and to everybody present. I mean, people just fall in and they don't even, because they're so used to being one of many faces, they don't care to actually establish a relationship with a patient. You can foreshadow the bad news. I mean, it's hard to do, but to say, listen, you don't have to say, I have bad news. You can just say, listen, we do have to have a challenging conversation today. I want you to take a deep breath. I'm here with you. Stop me at any time if you don't understand me, if you feel overwhelmed, but it's going to be a hard conversation. All right. You can touch the patient. Some patients will shy away from it. You learn to read people. Some patients will want to take your hand, or they will want some sort of human contact. Others will absolutely not. I think the most important thing is to assure the patient that you are available or that somebody would be available. And that is so hard in our system. I know that. I'm saying these things fully aware of how challenging it is. But ask the clinic sister, is there a number that the patient can call? Make sure there's a follow-up appointment on their cards, like bring them back for a next visit. And in private, this becomes a lot easier, but to make sure that they know you are not going anywhere, or at least the system isn't going anywhere, or there will be something or someone that can be contacted. Again, hard in our public service. Give them resources, a pamphlet, some form of, I know we don't want patients to Google, but if there is a reliable resource like, the NHI guidelines, it's quite patient friendly. If you can give them a link and say, if you've got airtime, go and Google this. For us, the Project Flamingo layer, okay, breathe and be present. Okay, so you have to learn how to self-regulate. This is the things that I've spoken about a little bit earlier. Breath work, touch. If you are centered, and I know it sounds a bit woo-woo and a bit whatever, but you can absolutely, your physical energy actually can influence the energy of the room around you. If you are calm, if you appear centered, if you appear sure of yourself, if you keep your tone of voice calm, centered, It influences. You can feel other people's energy. Try it for yourself. You can immediately feel it if somebody is nervous, if somebody doesn't have time, if somebody is frustrated, if somebody is scared, you can feel it. So try and learn how to work with your own energy in order to manage the energy that's around you. Okay. And in that self-work that we do, to be willing to witness distress and discomfort, because it does not come naturally to us. It is hard. It's hard being present with distress and with discomfort. Okay, so communicating well, like I say, for some people, it comes easier than for others. Things that you can train yourself to do is to very deliberately ask, okay, what does the patient already know? Okay, where is their level? Try and determine their level of what they understand of what you're talking about. You know, some people will not even, I kid you not, they would sit in alley 33 in the oncology clinic with me and they will not know why they had a biopsy. So my first question is always, can you remember that you had a biopsy? Did anybody explain to you why you had the biopsy? You literally start there. And then to be frank but compassionate. So this, again, it's such a nice sentence in the textbook, but it is to not try and soften things. So don't talk about die kankertjie, die kankertjie. Ag, ons gaan nie. Don't. It's cancer. All right? Don't hide behind big medical terms. I mean, it's easy to pop out. Yeah, you've got luminal B, a breast cancer that is T23N1, and that means absolutely nothing to the patient. Like, simple terms, but don't be scared to use words like cancer. Death, you read the situation, you read that carefully, and that if that is indeed the case, if we are dealing with a terminal patient, the first conversation may not be the one to drop that in there, but to say we are dealing with something serious, this is serious, that is important, not to euphemize that too much. Don't storm over their emotions. Allow silence, allow tears. I know it's difficult. If you see they have difficulty processing, stop. Ask them, do you want me to stop a little bit? Just, avoid the urge to talk and to overcome your own discomfort. Okay. And then actually have the patient repeat back to you what, say. So have you, what have you heard that I say? What is your takeaway? Where do you understand we are at this moment? Okay. And be very aware that the patient will not remember half or a third of the conversation that you've had. So write down. I always speak to a patient with a piece of paper in my hand. Write down keywords. Summarize, draw pictures so that they have something in their hand that they can walk away with from the conversation. Okay. And make sure you just summarize at the end and make sure they've got a follow-up appointment in the books. Our layer that we want to add on is to remember courage and compassion. So to know for yourself that bearing witness to human suffering takes tremendous courage. To be honest takes courage. To be hopeful, despite what statistics, whatever tells us, it takes courage. And to be fully present in this difficult exchange takes courage. So acknowledge yourself for being courageous. I don't think we give ourselves enough credit for doing hard things. And unfortunately, the system may not give you credit for doing these hard things, but learn to do it for yourself. And therefore allow yourself to not only extend compassion to your patient, but also to yourself, because doing this is hard. Okay. So dealing with reactions, this can sometimes be quite unpredictable. So you need to assess and you need to be very present. So this is where your own presence becomes really important to respond to emotional reactions. So people can have extreme reactions, from throwing themselves down on the floor, weeping, wailing, to somebody going completely numb, completely quiet, almost in a catatonic state, and to learn how to recognize it. Also learn how to recognize how some patients will immediately go into like a cognitive structure of they denying it. No, this cannot be true. You must be making a mistake. You made a mistake, or this is all, I know something, I knew something was wrong with me. It's this damn hospital. They didn't do my test, like I told you. Like they will go into blame. They will, some of them will like, no, I need all the facts. I need all the latest research. I'll need all. So there's various ways in which people will suddenly jump into a coping strategy. The best thing is to actually call it out when you see it. So to say, I can see that it's difficult for you to hear this news. And that is fine. That's totally fine. We will come back to it. For now, let's summarize what we've spoken about. Or I can see that you are angry, and I hear that you are angry. Let's take a deep breath. We can deal with your anger, and we will definitely address the concerns that you've had. But for now, let's summarize. Let's see what we've spoken about. There's that. Sometimes you need to call a second person into the room. You may call a colleague, you may call a senior person, just somebody to help you witness and deal with what is unfolding in front of you. Okay. Be empathetic. It is absolutely appropriate to say, I am sorry. And very importantly, it's very appropriate to say, I don't know. So when they start saying, what about this trial? What about that trial? To say, you know what? I know that you want to know all of that now, and I definitely am committed. I can go and read for you. I can go and get some of that question I can't answer for you, but we can go through what we've discussed. Okay, so just bring it back to things that you can manage in a kind and a compassionate way and in an honest way. And never argue or criticize colleagues. So when they say, yeah, Cole Bremer Hospital missed this, then don't go say, oh, yeah, those people in Cole Bremer, they're just terrible. No, you say, I am really sorry that this happened to you and that is how it feels to you at the moment. We will definitely look into your case. We will get your medical records. We will see, what happened where. Don't try and get to an answer. Don't blame. Don't shame. It's not worth it. Okay, just acknowledge what the patient is feeling. So that's our layer that we want to add onto it, is our D, dare to care, not to distance and not to defend. Okay, so it is hard, but dare to stay present, even though it feels with every fiber in your being. If you want to run out and shut the door, take a breath and dare to be present with whatever emotion is flying at you. Okay, and this is just where you have to learn again and again to recenter in the same breath, and also know when to say, if you can please excuse me, I will be with you. I'm going to give you a minute alone. I'm going to excuse myself for 2 seconds when emotion overwhelms you, or you feel you need a senior person in the room. So say, I'm going to give you 2 seconds, not so they feel you're abandoning them, but what you say, I'm going to give you a minute. I'll be back in 2 seconds or whatever. So stay present or do whatever you need to do to stay present. And if you notice something, to call it out. So to actually say, I see that it's difficult or to hear, or that you're angry, or that you are incredibly sad or overwhelmed, or calling it out helps to get the conversation going. I think the most important thing is to reassure them that you're not going anywhere, that you are here to ride the wave with them, at least for the consultation, even if you can't do it for their whole journey where you are in the public sector. And if blame and anger comes your way, you acknowledge it, and you suggest that everybody is allowed time and space to process in order to have a constructive conversation. Okay, you can invite them to write down their feelings and bring it to the next appointment. Okay, and document. So yes, medico-legally, very, very important to actually document hard conversations very well, but also in the Flamingo way, I want you to document this in the context of steadily building the life file called human experience. So every time you have had a difficult conversation, actually take the time to reflect for yourself. How did that go? What felt terrible? What did you think went well? How would you do something differently? That was a disaster. Debrief, basically. All right. It's important. If you can, with friends, if there's no senior people around to offer that for you, I know there should be. Find a friend. If you're privileged enough to have a therapist, a coach, really make it a practice to do that. Okay, and it's these to kind of go together to encourage and validate emotions. So you have to offer hope. I think we can always offer hope. Where there's breath, there is life and there is hope. Okay, but be realistic. Um, Explore what the news means to the patient. All right, so what may they need? Ask them, how can we support you? Is there somebody that you can call? Is there somebody that you're going to reach out to? And again, much easier in private than in state, but so important to realize that all of this really should be an interdisciplinary team. Okay, so social workers, psychologists, you get health coaches in private, hospice services, whatever, whoever you can pull in from the team, whatever is available, no matter how meager it may be in the public system, try and call on those people and try and pull them into the treatment journey of the patient. And then, very importantly, like we've said again and again, attend to your own needs during and following the delivery of bad news. So our flamingo layer, emotional intelligence, and validate emotions. That's not just for the patient, it's also for you. It is a skill that you can develop and grow. Okay, and I want to really encourage all of you again, start getting curious about it. Your job will be so much more fulfilling. It would be so much more doable. It would be so much more sustainable if you make your own emotional landscape a priority. So, learning to navigate your emotional landscape ultimately empowers you to navigate the emotions of others. Get curious about your own emotional triggers, patterns, and default coping strategies, because you will very, very easily start recognize it in others and mirror it back to you in others. So, and at the very core, in order to help others, we often need to help ourselves. So, people, this is why this forum exists. I know it's such a small, drop in the ocean, but steadily start building your network of support. Do whatever you need to do in order to help yourself so that you can help others. So that in essence is basically, if we talk about theory, skills, bits and bobs about speaking, having a hard conversation. Okay, so fortunately, we have at this point. So maybe let's do what am I going to do? Michelle is actually on the call, and I'm so glad that she is. So Michelle is one of our Project Flamingo directors, and Mich, I hope you don't mind me sharing, but Michelle is a breast cancer survivor herself, and her husband is also a pancreatic cancer survivor. So Michelle has got more experience than most of us in being at the receiving end of a difficult conversation. So I think there is no better person to actually tell you about hard conversations than somebody that's been sitting in a lot of hard conversations. Mish, if you had to give these youngsters some advice or feedback, or just something that you have experienced, something that's happened to you or Alan that has really impacted your journeys, like what would it be?
Sure, Liana, it's a hard task coming after you. Because you have the most incredible way of putting it out there at a very young age, relative to me. No, but you do, and I'm sure they'll all agree with me that you just have the gift of sharing your own experiences at a young age of from where you are. So much of what you put out there, I know it's a lot for them to read and kind of take in. It is a lot, and they can probably go back and reflect on a lot of what you've said. But so much of what you've said is pretty much what I would have raised and said. And I think probably to me, the most important, with all the experiences that I've had, and I have visited and sat with cancer patients and had those conversations outside of my own personal world and experience. But I think probably the most important, with everything else that you've said and all the other stuff that they've got to take into consideration, but I think the most important is just being present with the person that they are going to have that difficult conversation with, or discussion with, or follow up with. I think if the patient feels that calmness and that medical person's ability to understand, yes, they may not understand their situation fully, but to just let them know that you are there. You're not going to try and tell them a whole host of stuff that they need to do or shouldn't do or whatever. It's just that feeling that the person understands, has empathy, and will ride this journey with them. Most importantly, that it doesn't really matter what or how bad that diagnosis is, but that you never lose sight of what is our Project Flamingo mantra is, you never lose sight of hope. Because stats and everything else on paper, at the end of the day, means nothing really, and means nothing to that patient who has just received that bad news or is on that journey and follow-up appointments. That where there's life, there's hope. And you never know what may happen, what treatment may work, what may suddenly be discovered that can be shared. I know we're centering now in public health, but that to me is probably the most important, that patient leaves the presence wherever you have had that conversation with them, with just that warmth in them, that someone cares, someone understands, and someone actually took the trouble to listen, to explain, and to just be present in that moment. I think that's probably, from everything that you've put out there, I think that from my side, that is probably the most important, that the patient does not leave feeling completely gutted. I know it's different for each person, and some people can't take all of that in. I know of some of your patients that have literally walked out of the hospital and nearly got run over on the main road because they're in such a state. So it might not apply to everybody, but if there's just that little bit of feeling, and as you said, you give off that energy, and that patient will feel that. And if it's just that they walk away with, I think that's probably the most important. And as you said, it's not something you can teach. It's not something that you can read up. It's not something that you can prepare yourself with. And it's a hard, hard task to have to talk to someone about their diagnosis or about their treatment, or to try and be there. It's really, really hard. But from a patient side, the least and the best that you can get is just that feeling that that person is there for you and cares, and will be there, even if it's not the same person that you see next time around. But as you said, follow-up appointments, and just keeping tabs on the fact that that person is being taken care of on that journey. But other than that, Liana, you are amazing. You put out just so much stuff there, and I'm quite sure that everybody on the call here will agree with me that you have so much to offer and so much to share. Well done.
Thanks, Mish, and that's very kind. Thank you for sharing that. So, guys, questions. I know most of you have been exposed to difficult conversations. So, is there anybody that wants to share a hard conversation that you struggled with? Questions, practically things that you've run into that, you know, makes this hard to apply? Any questions, anything else? Just remember what I always say, I can only help you if you speak up. So questions,
Yeah,
comments.
I have a comment and a question, and yeah, thank
Yes.
you so much, Dr. Roodt, for this amazing advice as well. And yeah, I think this is something that has been close to my heart since being introduced to Breaking Bad News. Also, just from a family member that kind of heard a cancer diagnosis, got a cancer diagnosis from a radiographer that kind of just swung it out there, and oh, you've got cancer. And I think it's just it's something that I'm really passionate about, and sometimes it's really tough to have these conversations. Like as you were speaking, I was just thinking I'm currently in medicine, and I probably had to have 3 difficult conversations in the last week telling people, well, you have end-stage kidney disease. You're 40 years old, but there's most likely no help for you. And I think something that you said is that really helps, and for the other students that might struggle with this as well, is go back to basics and just ask, like, what do you know about why you're in hospital, or what do you know about, because sometimes I had a patient last week that didn't even know that he was supposed to get dialysis, that he had end-stage kidney disease. And so just to kind of go back and explain to them, and even just breaking an HIV diagnosis, which is something we do so often, if it's
And
not
flippantly.
done, yeah, and if we don't do it in a very sensitive way, and just and just make sure that the patient actually knows that they have been tested. I think it's so crazy to see how we so easily just can read the patient's notes on a ward round in front of them, and we think that they don't understand what we're talking about. But we're saying that we are concerned for a non-benign lesion. They just hop onto their phones and they Google it, and they figure it out. And I think that's something that's really helpful. Something that I did want to ask is about the calling in family. Sometimes I found that family members often like ask a lot of questions, and like makes the patient even a little bit more deurmekaar. I don't know, how would you just set the boundary with the patient so that the mother or the sister or whoever won't keep on jumping in? And
So I think it's a very useful comment, Marlu. I think family members can take over, and sometimes you end up managing the family member more than you manage the patient. So it's very important to learn the skill to very kindly actually call that out, and to say, you know what, I can see you are very, very concerned for your sister. I'm just going to ask, we're definitely going to get back to your questions. Just want to take us all to take a breath and ask the patient, can I have 5 minutes with you alone, actually? Or at the very start of the conversation, if you see things as it's like, you know what, do you want us to continue? Ask the patient. They will tell you, no, I want them to go out. They'll often tell you, I want them to go out. And then you say to the family member, you know what, I will chat to you afterwards. I will answer all your questions. Here's a piece of paper, go write down your stuff. But I just want to spend time with your mother, your sister, your whatever right now. They need me. You actually need to learn to call out people's behavior and stop them. When it gets too much, you say, you know what, I recognize you're so concerned. Let's push pause for now. Let's just deal with what your sister's going through, what your mom is going through. I'm gonna ask them to just tell me, to speak to me right now, and then at our next consultation or whatever, we're gonna really address all your questions, and we're gonna go into it. And then also make sure you ask even though if you say bring somebody along, whenever somebody walks into a consultation room, in any case, you are supposed to ask, do you want this person here? We need to have a chat? Can this person stay? So actually ask the consent of the patient, for the family member to stay, because some family members will just barge in and right over the patient. Jess, I think you've got your hand up.
Thank you so much, Doctor. Yeah, I think something that I've noticed quite frequently, I mean, I was in peds and I'm in obs and gynae, and I think sometimes, although difficult conversations are not as common in the obstetric side, there are like specific instances. And there was actually one that happened today where we diagnosed an intrauterine fetal death. And the MO actually forgot to tell the patient the outcome of that scan. So as we were now moving her from like the front of labor ward to the back so that she could actually now deliver the baby, I was like, listen, like we need to actually tell this mom. I mean, we need to tell her what's about to happen. And something I've just kind of noticed with over the last 6 months, doing internship is that sometimes I think it's easy to become a little desensitized if you are dealing with
100%.
like the tragedy on a daily basis. It's your bread and butter as a doctor. So sometimes to remember to take that step back and realize that even though this is maybe your fourth breast cancer diagnosis of the day, like it's life-changing for the patient. And it's so important to take that moment just to realize the impact of the diagnosis you've just made and just create that space for the patient to absorb that information and ensure they fully understand it. Because I've noticed too frequently that I think we rush over that part too much because now we know what's wrong. Let's like get them out the door and see the next person.
Yeah.
But yeah.
No, Jess, thank you so much for bringing that up. And my heart just like went, when you told that story. That's terrible. I actually want to cry. This is why we're having this, right? Because we're trying to raise and train a new generation of doctors. We're getting to a diagnosis is not the aim, but to actually provide healing is the aim, right?
Yeah.
We forget that because we are, and this is why I know you're going to get so sick and tired of me, and you're going to say this woman is like, but when I say working on ourselves, working on our interior space, like this is hard internal work that I'm asking you to do because I know as sure as shit the system is not going to do it for you, and it's not going to provide an environment for you as it stands where that is encouraged or modeled or that's the example. So this is honestly, when I say I believe that you are a new generation of not just doctors, but a new generation of healers, this is why we're having these conversations. And this is why it's important for you guys to remember these stories as we're telling it to each other, to keep telling it to each other, to keep putting in place whatever you need to put in place to keep this human side of you alive, because this profession will eat you alive if you don't do that in a very conscious and deliberate way. Okay, so somebody else has got her hand up. You bad? I don't know who. You bad? Hi.
Can you hear me?
Yes.
Perfect. Thank you so much for today. It's been incredibly insightful. Something I wanted to sort of comment on as well, just from my experience, is I find it very helpful to also give patients practical tips as well as like maybe just outlining what may lie ahead for them. Because I think that's something we also underestimate is you give the diagnosis and maybe even the prognosis, but very few patients in the public setting even know what chemo is or what they might be going through. And just explaining a little bit what it's going to be like, I think also eases their mind a little bit. Of course, being careful 100%. Not to overshare, but yeah, I think it's also like a bit of health advocacy with that, suggesting that they mention a chemo port, because not all doctors think of that all the time. And I think it's very helpful for some patients to get one put in if needed.
Yeah, 100%. No, for sure. So that's where that preparation coming in, and actually the drawing and the writing down while you're talking and sending the patient away with something in their hand. Practical, like you say, practical tips, pamphlets, websites, whatever. It helps an enormous amount, helps the patient to prepare for the next conversation where you may not be present and you don't know who they're going to get. So actually, giving that input and giving what you can in yeah, in a boundaried way, but definitely so helpful to give them those practicalities, and go and do some research, stuff that you see often, like breast cancer or colon cancer or HIV or diabetes. Just go and play a little bit on Google and see what you can find that for you seems like a safe and a reliable resource that you can start sharing with patients, because we don't have that available in all our hospitals. In private, all of this is a lot easier. But you'll be shocked to see how few people actually use it properly. But yeah, very valuable comment. Thank you so much. Okay, anybody else? Don't see more hands, but thank you. Okay, guys, so I think that was, I mean, it was a big conversation, and I'm always happy to revisit, always happy to do more of it. So this will go onto the website. So if you've got friends, colleagues, whether it's students, interns, MOs that you want to share the resource with, it's free. They can just access it on the website. And if you have topics for our next webinar, so please share with Lou. Will send out a survey again. I know it's a pain in the butt, but it's very quick to fill it in, but it really helps us, because it kind of guides me as to where the need are, what you guys want to talk about, whether what we're doing is actually useful or not. So thank you for taking this hour. I'm very proud of all of you for doing it. I think this is it's very encouraging to see you guys caring enough to take the time, and to take the time for yourself. So please look after yourself, stay warm, and have a very blessed week. Bye.
Bye.
Thank you. Bye. Bye.
Thank you.